Hello doctors, let me introduce myself first. I am Dr. Avaranjika Karupasamy and in this session we are going to study ENT completely with me. So let's start with ear now. So first let us start with the anatomy of external ear. So here in case of anatomy of external ear we have three parts. One is pinna, that is the external one, and the external auditory meatus and tympanic membrane. So that was some idea. So this is the pinna and here comes the external auditory meatus and here comes the tympanic membrane. So this is completely called as external ear. So let's get in detail with it. So here pinna, let's start with it. It is completely made of yellow elastic cartilage except the lobule. You people might have felt this cartilaginous feel even before. So it is completely of elastic cartilage. So this is important, whether it is elastic or hyaline. So here pinna is of elastic cartilage, and here it is mentioned that the lateral surface of pinna, that is the external part which we can see, is comparable to fingerprints. So it can be easily used for the identification of persons even. So if our government might be knowing, they might be thinking about adding in Aadhaar also. So here in case of pinna, the interesting thing you should know that there are muscles, totally 9 muscles in pinna. So there are 3 extrinsic muscles and 6 intrinsic muscles. So in case of extrinsic muscles, they were auricularis anterior, auricularis superior and auricularis posterior, and they are supplied by facial nerve. And here in case of intrinsic muscles, they are 6 in number. So in case of arterial supply of pinna, you can remember pinna is of PINNA. So P and N, A you can take. So it is posterior auricular branch of external carotid artery. So the arterial supply is by posterior auricular branch of external carotid artery, and lymphatic drainage, it is by deep cervical nodes. So let me repeat again. So in case of external anatomy of external ear, we have pinna, first part, and here it is made up of yellow elastic cartilage. So try to remember, it is not of hyaline cartilage. This is also an important MCQ, and then it is even used for the identification of persons, and there are 9 muscles totally, 3 extrinsic and 6 intrinsic muscle, and arterial supply you can remember with the help of this P and A, that is posterior auricular branch of external carotid artery, and lymphatic drainage is deep cervical nodes. Then, so now we are moving to the next part. That is external auditory canal, that is the second part of external ear. So it develops from the dorsal part of first branchial cleft. So in case of embryology point of view, these MCQs are very important regarding the branchial cleft, branchial arches, regarding aortic arch. You should know what are all the parts developing from it. And here the external auditory canal is of 24 millimeter and it is of A shape. So whenever we are examining, you might have seen in the OPDs even, whenever you are examining the external auditory canal, you have to pull it above and outwardly so that this S-shaped curve would be visible easily. So here there are, in case of external auditory canal, there are 2 parts. One is cartilaginous and one is bony part. So outer one is cartilaginous and the inner one is bony part, and here the most important thing, outer 1/3 and inner 2/3. So the bony part is more, you can remember like that, and the millimeter is 8 plus 16, which is 24 millimeter. Don't confuse. Outside it is of cartilaginous and it is of small, and the bony part, it is the inner one and it is of long length. Okay. So here in case of cartilaginous part, there is deficiency in the posterior superior area, and here in case of cartilaginous part we have hair follicle, sebaceous gland or ceruminous gland, where the sebum is getting secreted and sometimes gets accumulated, which is called as earwax. Our most common clinical condition we can see. And in case of bony part, there will be no hair follicles or glands, and it is 5 millimeter lateral to the tympanic membrane, and there is a narrow part in the bony meatus which is called as isthmus. Okay. So now in cartilaginous part, there is a deficiency in anterior part of the cartilaginous one, and that is called as fissures of Santorini. Okay, fissures of Santorini. So here what happens, because of the deficiency, infections from the mastoid region or parotid region can extend easily into the ear. Okay. So here in the same way in case of bony part also there is foramen of Hashke, which is a deficiency in antero-inferior part. Okay. So here it is anterior part and here it is antero-inferior part, and here it is fissure of Santorini and here it is fissure of foramen of Hashke. Okay. So here also the infection will be spreading from the parotid region. So I am just repeating: external auditory canal, which is the second part of external ear, and here it develops from the first branchial cleft, and it is of 24 millimeter, and there are two parts: cartilaginous part and bony part. So cartilaginous part, outer one third, that is 8 millimeter, and the inner one, that is 16 millimeter, and here it is deficient postero-superiorly, and there will be sebaceous glands, but here it is exactly opposite. There is no hair follicles or gland, and the narrowest part, which is 5 millimeter lateral to the tympanic membrane. You can imagine like this. This is the tympanic membrane and this is the external auditory canal. So here if there is any narrowest part, that is isthmus. Okay. So here it is for a fissure of Santorini and here it is foramen of Hashke. Okay. Next. So here the blood supply is of external carotid artery. Nerve supply, there are different based upon the different walls of the external auditory canal, there are different nerve supply. So anterior wall and roof is supplied by auriculotemporal nerve, and floor and posterior wall is supplied by Arnold nerve. Try to remember it, Arnold nerve, which is none other than the auricular branch of vagus. So try to remember that Arnold is cleaning the floor. Okay. So here, because of the stimulation of auricular branch of vagus, we always get two different phenomena, which is so interesting. You might have also observed that. One is vasovagal reflex. So while cleaning the external auditory canal, we used to have a cough, and sometimes because of the stimulation of vagus, we may expect bradycardia, and if it is very severe, it may lead to syncope and cardiac arrest. So just see how much it is dangerous. You might have experienced the coughing, so try to tell the patients in the clinics also not to do manual cleaning of earwax as people used to do with any instrument they used to put in the ear, and they develop these type of issues. And sometimes appetite also increases because of the vagal innervation. So in case of posterior wall, this is very interesting phenomenon. It is supplied by facial nerve, and there is one particular sign called as Hitzelberger sign, which is more important in practice of medicine point of view. That is what happened, because in case of facial nerve injury, there will be hypoesthesia, that is sensation will be reduced in the posterior meatal wall. Okay, so this you have to remember. So blood supply, external carotid artery, pinna is supplied by the posterior auricular branch of external carotid artery, same. Nerve supply, anterior wall is supplied by auriculotemporal nerve. Floor and posterior wall is supplied by auricular branch of vagus, which is also called as Arnold nerve. And vasovagal reflex and appetite will be increased whenever the auricular branch of vagus is stimulated. Then posterior wall, it is supplied by vagus nerve and Hitzelberger sign, that is none other than the hypoesthesia of posterior meatal wall, which is seen in the facial nerve injury. So let's go next. Now comes the third part of external auditory meatus. So here in adult it forms an angle of 55 degree. You can imagine this degree, like this type of degree we can expect. So 55 degree with the floor of external canal, and the surface area is of 85 square millimeter, and on examination you might have seen it is a purely grey color. And here this Gasserian fissure, which is associated with tympanic membrane, has the anterior malleolar ligament. So these are all the important MCQs along with tympanic membrane. So now in case of tympanic membrane, before going in detail, let me draw the diagram. So this is the tympanic membrane. I'll explain you. So in case of tympanic membrane, we have two things. One is pars tensa, which is a vibrating surface, and here it is pars flaccida, which is also called as shrapnel membrane. So let me show you where it exists here. So here this area is pars tensa, which forms the major area, and this one is pars flaccida. Okay. So here it is mentioned that the periphery is thickened to form a cartilaginous ring, that is annulus tympanicus, which you can see here. So this peripheral thick cartilaginous ring is called as annulus tympanicus, and this ring is deficient above in the form of a notch called notch of Rivinus. Okay. So there is a deficiency, and which can be called as notch of Rivinus, and in the central part it is tented inwards. So this here it is, wait, I'll tell you. The central part is tented inwards at the level of tip of handle of malleus and is called as umbo. So here is the tip of malleus, which is from the inside of the tympanic membrane, and this area is called as umbo, which is the most reliable landmark of otoscopy. So here cone of light. This cone of light is also seen in the antero-inferior quadrant. Okay. So this umbo is here, and this area we can see the cone of light. So these are important MCQs related to this tympanic membrane. So basically tympanic membrane used to be like this, but here we are seeing in different cross section. So try to understand it. I'll explain you again. So here in case of pars tensa, which is a vibrating membrane, all this area is pars tensa. Okay. And here this area is pars flaccida. And here there is a deficiency that is called as notch of Rivinus. And here in the central part, here it comes the handle of malleus, which is the bone in the middle ear cavity, and here near this, in this area, this is called as umbo. Okay. So which we can which is called as the most reliable landmark of otoscopy. And here we can see the cone of light. In MCQs we used to see like cone of light is seen in which quadrant, that is antero-inferior quadrant. And then comes pars flaccida, that is shrapnel layer, here it is, and flaccid to allow the movement of head of malleus. You know that this is the handle of malleus. So here comes the head of malleus, where it is very flaccid. The name itself indicating that it is very flaccid, and here it is very dense. So based on that the function will be there. Okay. Next comes the blood supply. So here the major blood supply is maxillary artery, and in case of nerve supply, You can see here in the outer surface, it is by the antero-inferior part of auricular temporal nerve and postero-superior part of vagus nerve. And here in the inner surface, it is by the tympanic branch of glossopharyngeal nerve or Jacobson nerve. So, don't confuse the Arnold nerve. Okay, Arnold nerve is a branch of vagus, and glossopharyngeal nerve and Jacobson nerve are similar. Okay, don't confuse it. It may confuse if you don't know that, if you don't study the difference between the both. Then comes the few MCQ facts related to the external ear, tympanic membrane. So if there is central perforation of pars tensa, it is called as safe CSOM, that is chronic suppurative otitis media. And then if there is marginal or attic perforation in pars flaccida, it is an unsafe CSOM. If there is multiple perforation in tympanic membrane, it is indicating tuberculosis. You might have seen this in our drug tuberculinum, where where there are multiple perforations in the tympanic membrane. Then comes multiple blebs or hemorrhagic blebs, that is bullous meningitis. And then comes granulation tissue on tympanic membrane, that is called as granular meningitis, which is seen there. And hemorrhagic blebs are petechiae, that is because of barotrauma. Barotrauma, because of pressure changes. And central perforation, that is tubotympanic or safe CSOM, that is another name. If there is marginal or attic, we already know it is an unsafe CSOM, which is also called as attico-antral. Okay. So, meringotomy incision is made in the posterior-inferior quadrant. This is not so important because we are not dealing with the incision part. So, here if there is central perforation, it is safe CSOM or tubotympanic CSOM, or marginal or attic perforation in pars flaccida is called unsafe CSOM or attico-antral CSOM, and multiple perforation tuberculosis, multiple blebs or hemorrhagic blebs, bullous meningitis, granulation tissue on TM, that is granular meningitis, hemorrhagic blebs, petechiae, that is barotrauma, then central perforation, as I had already told, these 2 points were discussed, and meringotomy incision, posterior inferior quadrant. So, cone of light is in the antero-inferior quadrant. Don't forget that cone of light.